we are investigating new EGFR inhibitors. This has really been our first great success in the modern era of lung cancer therapy is learning how to find patients with EGFR mutations and how to treat them with EGFR inhibitors with very successful drugs. Unfortunately, the length of benefit is not as long as we would like. And so we have many patients that need a new drug to be treated with following erlotinib, Tarceva. We know that most of the time, about 60% of the time that Tarceva stops working, it's because the cancer cells have developed a second mutation. They still have the EGFR mutation, but they've developed another mutation called T790M. And what that mutation does is it adds a protein arm that blocks the place that Tarceva should be binding to. And that kind of physical interaction is enough to stop Tarceva from working. What we have looked at, and we have a few drugs that are leading the way here, is new ways to bind into that same place that avoid that protein arm, that blocking arm, or we call it a gatekeeper mutation. And there are a few drugs in this area, and one of the ones that I've worked most with is CO-1686. It's also an oral drug, generally very well tolerated, and it does fit that criterion of inhibiting these cancer cells that have become resistant to Tarceva. As an additional benefit, these drugs have been designed not to inhibit what we call the wild type EGFR, the non-mutated EGFR. So you do away with most of the Tarceva side effects. Patients are not getting rash, they're not getting diarrhea. So you have a better tolerated drug that may be effective following Tarceva. A question that we hope to be looking at soon is, could it be better than Tarceva head-to-head for patients that are getting their first EGFR treatment? But in any case, it looks like this is going to be an important step forward, and there's several drugs in this category that are looking exciting.